So our first speaker today is Dr. Nikhil Ahluwalia, who is a registrar at Bart's Heart Centre, and he's going to talk to us today about arrhythmic cardiomyopathy. Thank you.
Great. Hi, everyone. I'm just going to share my screen. So if someone can just confirm, they can see my camera at the moment, and then now also my first slide.
Yep.
Great. So thank you very much to Dr. McGill and the RSM for asking me to give this talk. I'm an EP registrar, but currently out of program doing my PhD at Bart's Hospital. And I think the reason I'm giving this talk is because this is the focus of what I'm working on for my PhD. So arrhythmia-induced cardiomyopathy, and really some of the controversial areas within it and key questions that we come across is what I'm looking at as part of my research. And so I'm not going to focus on the sort of basic understandings that I'm sure you all have gathered through your cardiology training so far, but really I think the points that I've learned whilst doing my research and reading up on this area, and also doing some clinical work on these group of patients, the really points that I'm going to try and drill home today are just the aspects that I wish I'd knew at the start before I started this PhD, and also the new things that I've learned whilst looking at this group of patients. So again, not going to patronize you by telling you how common atrial fibrillation and heart failure are. I think that one of the points that I really want to make here, though, is that they do coexist in a very large number of patients. So we're not talking about a minority of patients. Of your heart failure patients, somewhere around 40% of them will have a concomitant AF. Now, that doesn't mean they all have arrhythmia-induced or arrhythmia-mediated cardiomyopathy. And really one of the main questions I'm trying to answer in my research, and I think one of the main questions that we all try and answer every day when we see these patients, in clinic and on the ward, is which of them have arrhythmia-mediated cardiomyopathy and how many of them have bystander AF and heart failure from other reasons. And I think that discrimination and differentiation is one of the things that a cardiologist is consulted for, or one of the reasons why a patient will come to see you in clinic, and one of the key questions you should always be asking yourself when you see a patient with these two conditions. Because our treatment for heart failure, as I'm sure you'll see throughout the day and throughout these series, is becoming more and more personalized. And for us to be able to treat heart failure, we need to know what's driving the heart failure in those patients. And later on in the day, you'll find that patients with a broad left bundle branch block, when you resynchronize their heart, they will improve their cardiac function. But of course, if you try that same therapy in someone who doesn't have that driver, it's a waste of time, money, and risk. And so you need to try and figure out which of the AF and heart failure patients have AF-mediated heart failure, AF-mediated cardiomyopathy versus the patients who have bystander condition. And looking at the numbers to try and figure out how common this condition is, I think it's somewhere between 50%, right? A third to 50%. And I've just got some of the data on the screen here of, consultant electrophysiologists trying to select the patients that they think have got AF-mediated cardiomyopathy. And we've looked back at how those patients do after their ablation. Because if you think someone's got an AF-mediated cardiomyopathy, then it's reasonable to think if you get rid of the AF, you'll improve the cardiomyopathy. And so in our several series that we've sort of published over the last decade or so, I think we get it right about 2/3 of the time, but that still leaves a large chunk of patients that we're putting through procedures, putting through medical treatments, and that they potentially are not going to gain benefit from. And so if we at the moment as consultants and registrars who see these patients day in, day out are getting it wrong, how can we expect other people to be getting it right more than that? So we really do need markers to help us select these patients better. And thinking about the flip side, how many patients have we seen with AF and heart failure that we have not put forwards for rhythm control treatment when actually the AF may be mediating their heart failure? So we need better ways to try and select and discriminate our patients with AF-induced cardiomyopathy. So today, what I'm going to cover is really that process of how we pick out these patients with AF-mediated cardiomyopathy. I'll look a little bit at the mechanism of how AF can drive it and see if that gives us any insights. And then finally, I think the other big thing that I've learned over the last few years working in this area is that I've seen, is there something that's completely reversible, right? So if we get rid of the AF, do we fully reverse the cardiomyopathy? And I guess initially I thought the answer was yes. Once you get rid of the cause, you completely reset and remove the cardiomyopathy and go back to normal. But actually, more and more the evidence is showing that actually you don't actually get that full reversal, and that may need certain changes in our management of this group of patients. But to begin with, just to give us a bit of background, let's just go through a case which I'm sure many of you are very familiar with, having seen in your clinic. So this is a patient who I interacted with a couple of years ago, but he'd been under Bart's care for many years at the time, so almost 10 years when I met him, and he had a background diagnosis of an AF and what had been labeled as a dilated cardiomyopathy, which showed a severe LV function, and it was all related around this alcohol binge. And so he underwent an ablation and had a really good result. And his echo, after he'd gone back into normal rhythm, showed a recovery of his ejection fraction, LV chamber dimensions. And so all in all, he was discharged at that point because he was believed to have had a reversal of his AF-induced cardiomyopathy. He'd also given up his alcohol, so maybe that had also contributed. He then presented in 2018, and I'd been called down when I was on call to see this patient who'd come into the echo department because he'd had these images taken when he'd come in for his echo scan because of shortness of breath symptoms. And I think it's quite clear to see that this gentleman's LV function is severely impaired. I mean, his biventricular function looks impaired, but LV function particularly, and there may be an element of LV dilation going on there. And if you look at his ECG at the time, you can see that he'd gone back into what looks like probably an atrial tachycardia, but some sort of tachycardia here, and so was given the presumptive diagnosis of a recurrence of atrial tachycardia, atrial fibrillation, well, atrial tachycardia in this case, and a subsequent AF-AT induced cardiomyopathy. So he was brought in for an urgent cardioversion. Normal-ish rhythm was restored. As you can see here, he doesn't have a tachycardia anymore, but he still has some PVCs that were coming through after the cardioversion. And on repeat echo, I think you can see that there has been an improvement in the function there, but I wouldn't call this a normal ventricular function. And of course, as you can see on the rhythm strip on that echo, that PVC is still causing some dyssynchrony there. So, further optimization needed. And once we got on top of his PVC burden with some optimization of his beta blocker dose, he went for an MRI. And on this MRI, I think you can see one of them as videos and one of them as a still. What was reported shows that the patient still had a degree of mild to potentially moderate LV impairment of the ventricle, even though he was in normal sinus rhythm. There wasn't much scar, and there wasn't any perfusion defects to suggest there was another cause going on here. So really, this sort of challenged the initial diagnosis that we'd made on 2 occasions, that this patient had a arrhythmia-induced cardiomyopathy, AF-induced cardiomyopathy, which did improve, and then it improved a second time, but it's not gotten all the way back to normal. And so, what do we label this patient? What does this patient need going forwards? And I guess the question is, if they were to go back into another atrial arrhythmia, what would you offer them then? So really, what I'm showing in this case is that the answer is not as clear-cut as we like to think, that if you take a patient with AF and a cardiomyopathy, get rid of the AF or atrial tachycardia, you get rid of the cardiomyopathy. There is a lot of gray even within this condition. So really, it's about how you handle some of the nuances. And I think to try and do that, you need to have a better understanding of what could be going on here and what we would expect to see. So very briefly, let's just take a step back for a second, because one of the questions that I asked when I was trying to devise a research question was, is this all actually just tachycardia cardiomyopathy? And then tachycardia cardiomyopathy is well established. Going back 30, 40 years, we've got strong evidence from animal models that tachycardia, cardiomyopathy is a thing. And it's such a good model, such a reliable model of causing heart failure, that in animal studies of heart failure, it's often used to simulate the heart failure model. And so rapid pacing has been shown to cause acute hemodynamic dysfunction, impairment, and even a chronic heart failure model. So, you know, the relationship between fast heart rate and cardiomyopathy is clear. It's useful for people who want to study heart failure, but it also gives us a really nice picture of the sequelae and timeline through which fast heart rhythms can cause LV dysfunction. And in animal models, at least, in the first 3 days, you start to see dilation of that chamber, you start to see dysfunction of the LV. And after that point, really in the 3 to 7 day mark is when you start to see, after sort of the 3 to 7 day mark is when you start to see increase in those pulmonary pressures, systemic pressures, and you start to see really high wedge pressures as well. So it's after 1 week that you start to see those systemic changes in cardiac function occur in this model. And if you really want to break it down into that cellular histological change that we're seeing when you pace someone's ventricle fast, or when someone has an atrial tachycardia or ventricular, you know, another reason to be going tachycardic in the ventricle. I've written some of the key insights on a cellular basis here, but the one that I really want to focus on is the one that I've highlighted in red, that this appears to be a calcium handling mediated process. And a lot of the studies have implicated something called juncophyllin, which is essentially a bridge that helps hold the calcium handling apparatus together on an intracellular level. And once you get repeated rapid pacing of the heart, those juncophyllin bridges tend to break down, and you get a deterioration and a breakdown of that calcium handling mechanism inside the cell. And it looks like that if you break the tachycardia early enough, you can get a reversal of those histological changes. But if that process continues too long, then that breakdown can be irreversible and cause further problems down the line. So, you know, that it looks like there is clear histological agreement about how this process happens, which supports that relationship of tachycardia can cause cardiomyopathy. And actually, that relationship is so clear that in the latest ESC guidance from, I think, from 2020, it's one of the only, well, I think it might even be the only class 1 indication for AF ablation. Okay, and that's because of the strength of this relationship, that even if patients with tachycardia are minimally symptomatic or even not symptomatic, but they have a strong suspicion of a tachycardia cardiomyopathy, you should strongly consider rhythm controlling them with catheter ablation. And, you know, so that making this relationship and establishing this diagnosis is incredibly important because of the strength of that relationship between tachycardia and cardiomyopathy. That's what the guidelines say, based on you know, a wealth of evidence that shows that relationship. So that when you see these patients in clinic, it's one of the strongest indications for onward referral to, you know, whatever your ablation pathway is in your hospital, at least for consideration of that, because that relationship is clear. And yeah. So is that it? Like, is tachycardia the only driver of arrhythmia-induced cardiomyopathy, or is there something else going on? And the reason that's important is, if it's all just about the tachycardia, then if you appropriately rate control a patient with atrial tachycardia, atrial fibrillation, then it's problem solved. And actually, it doesn't look like that answers all of the question here, that tachycardia is not the sole culprit in conditions like atrial fibrillation. And I'm going to focus on atrial fibrillation for a minute, because that's a condition where you have a tachycardia, an irregularity of that ventricular contraction and that diastolic period, and you also have a loss of that left atrial function. And so if it's all tachycardia mediated, then once you've rate controlled it, the patient, then that's it, problem solved. But actually, what about those other two mechanisms? And I put up a line chart here, which shows a study that was done, I guess, 2 decades ago now, where patients who were undergoing an AV nodal ablation had some hemodynamic studies done after that procedure. So these patients all had AF, permanent AF. And what the investigators did was they recorded that heart rhythm of the patient when they were in AF. They then ablated the AV node so that the pacemaker could set the ventricular rate and rhythm, and then paced them in two different ways. The first was they paced them according to what that AF rhythm was. So they replicated it. So you had an irregular paced rhythm. And then they averaged out what the ventricular rate should be and paced them at the same rate, same average rate, but at irregular intervals. And what you can see from the line graph is on the acute hemodynamic level, if you pace someone irregularly at the same rate, you have a lower cardiac output. And this has been shown in humans here, but previously it's been shown in dog models. But of course, models are limited in how we can translate them into practice, because as you can imagine, this is taking a lot of assumptions that about the impact of right ventricular pacing and the dysynchrony caused by that and how that may impact left ventricular function as well. But it at least suggests that there may be an additional mechanism beyond just the tachycardia that causes the cardiomyopathy. And there's also some intracellular in vitro model data that shows that irregular activation of a cell can cause problems with induced calcium reuptake in this case. But again, part of that calcium handling mechanism on top of the dysfunction that's induced by tachycardia. So both tachycardia and irregular heart rhythms can and have been shown to affect the calcium handling, which can affect contractility. So it does look like that the cardiomyopathy induced by arrhythmias is beyond just that of tachycardia. So again, going back to our case example, the one thing that I really want to pick on a little bit is that it's never really as black and white as we want it to be. And one of the big questions that I think we all face in clinic is what's the cause here? Is the AF causing the cardiomyopathy, or the arrhythmia causing the cardiomyopathy, or is it the other way around? Is the cardiomyopathy causing them to have the arrhythmia? And that's what we're looking at. So that chicken and egg scenario of what's causing what is really difficult when a patient presents to you for the first time with both, arrhythmia and cardiomyopathy. And sometimes, we can think that we know what's going on. And often, let's say a patient has got known coronary artery disease, a previous bypass graft, we can sometimes think that, they've got a pre-existing reason for cardiomyopathy or cardiac dysfunction. The AF is probably a result rather than a cause. But what we know is that if you still take those patients, is that you can have multiple causes of cardiac dysfunction. And yes, the coronary disease and the ischemia may cause a degree of cardiomyopathy, but you may have a compounding effect of a second problem caused by the arrhythmia that you can potentially treat. So just because someone has one cause for cardiomyopathy, that does not mean that they do not have another cause. So it's not that, I don't think you can be as black and white again there, that if someone has a cause for a cardiomyopathy, they can't have AF or arrhythmia-induced cardiomyopathy, right? So you should still keep an open mind, because they are probably just as vulnerable as someone who walks into your clinic with no other cause for their cardiomyopathy apart from the AF. There's no reason why, just because you have a preceding diagnosis of ischemia or hypertrophic cardiomyopathy, that you can't develop overlying arrhythmia-induced cardiomyopathy. So I don't think that is a strong reason to think the patient doesn't have arrhythmia-induced cardiomyopathy. The other thing that can be helpful is timing. If you know a patient has severe LV dysfunction and then develops AF, yeah, great. I mean, that's really useful to help you understand the timeline and sequelae when you re-image them. But that's rarely what we see in practice. What you often get the patient presenting with both at the same time when you first make the diagnosis, when you first see them in clinic or in A&E. Or you can have a patient with some sort of degree of cardiac dysfunction, cardiomyopathy. They then come to see you with the AF or arrhythmia, and they've got a worsening function. So is that progression of that underlying cardiomyopathy, or is this something completely new because of the arrhythmia? Really difficult to say. And finally, there's been some evidence to suggest that the amount of left ventricular scar helps predict patients with non-arrhythmia cardiomyopathy. So patients without scar on MRI maybe the ones with arrhythmia-induced cardiomyopathy, and maybe the reversible ones. But there's, again, recent evidence coming out to show that if you have sustained arrhythmia-induced cardiomyopathy, you can develop that same scarring of the ventricle if it occurs for a long period of time. So again, not completely black and white. So, the thing is, it's still very difficult. And I'm not going to sit here and say there's a clear answer to this, but I think it's something that we always need to bear in mind, that just because someone has another reason for a cardiomyopathy does not mean they can't have arrhythmia-induced cardiomyopathy. And conversely, just because someone has arrhythmia-induced cardiomyopathy in your mind and you treat the arrhythmia, that doesn't mean they don't have something else underlying it going on. If you go back to our case example in that first patient, with the benefit of hindsight and a couple of years after that interaction, that gentleman did have a very clear arrhythmia-induced cardiomyopathy. On 2 occasions, his arrhythmia was dealt with and he was given rhythm control and put back into normal rhythm, and he had a clear improvement in his cardiac function. However, over time, it does look like he has another process going on, and he is currently under our inherited cardiomyopathies team undergoing workup to try and see what his underlying cardiomyopathy condition is. So it's a circumstance where you probably have 2 different conditions going on, and you should probably try and treat both of them. Now, what does that treatment mean? Going back to our animal models and the cellular intracellular pathways, a lot of that overlaps with what we see in other heart failure conditions. Okay, so this is still heart failure cardiomyopathy and should still be treated in the same ways you would treat other cardiomyopathies in terms of medication. So guideline directed medical therapy with early establishment and initiation and rapid up titration safely should be done in these patients as well. And really that's still a foundational treatment for patients with arrhythmia-induced cardiomyopathy. I've just brought up here some data from Imperial, which I thought was a really nice study that shows that even once you've got on top of that ventricular function, and that ventricular function is improved in patients with non-ischemic cardiomyopathy here, not necessarily just arrhythmia-induced cardiomyopathy, but once that ventricular function is improved, if you pull back on that guideline-directed medical therapy, so you pull back on those heart failure drugs, you do risk that ventricular function decompensating. And so it is really important to consider, trying to maintain that medication, even if a patient has improved. And that's a really difficult conversation to have with a patient, because on one hand, you're trying to explain to them that the arrhythmia is the cause of your cardiomyopathy, so we've got to treat the arrhythmia. And a lot of patients want to get off medications. And so it's quite important to be open and honest with them right from the onset to say, yeah, we'll treat your arrhythmia because we think you've got arrhythmia-induced cardiomyopathy. But that might not necessarily mean you come off all the heart failure medications. And I think it's a decision that should be led by the patient with knowledge of this data to make that sort of informed decision. And you've got to be clear about that up front. So they shouldn't be under any misconception that once they've had the ablation, come off all heart failure meds, and stop taking all drugs. So that's not what should be recommended from an evidence-based perspective. Now, going back to what I said right at the start is, once you've treated the arrhythmia, does everything go back to normal? And it looks like the answer there is no. You still have a degree of cardiomyopathy. You see a significant improvement in treating these patients with arrhythmia-induced cardiomyopathy, but the ventricular size and the ventricular function on nuanced assessment does not go back to normal. And there's, it depends how you measure cardiac function, but if you're using LVEF with a binary cutoff of 50%, yeah, you will see improvement, right? But that does not mean normalization. That does not mean the LV chamber sizes go back to normal. That does not mean the LV energetics go back to normal. And that does not mean the contractility on more nuanced measures goes back to normal. And actually, we're seeing that even in patients who have got a diagnosis of arrhythmia-induced cardiomyopathy, who have a significant improvement in their function, you don't always get back to normalization. Again, another reason to keep going with those medical therapies. So really, just to summarize what we've spoken about there, really is continue the guideline-directed medical therapy. I think imaging is really important, just so you have got something to look back on and measure how much that change has happened. I think it's also really important to still image and monitor these patients after you've treated their arrhythmia, because like I said, often there can be a second process underlying that only becomes manifest once you've got rid of the the main cause, or what you think is the main cause, which is the arrhythmia. So these patients can have something else going on, and it's important to be aware of that and pick that up. And finally, just a final slide on PVC-induced cardiomyopathy, just to say that these processes are quite, in some ways similar, some ways different. You may not have the tachycardia-induced component, but what you can have is this irregularity-induced component from a PVC. And again, this is another talk in itself, but the reason I want to mention it is because it's so common in our clinical practice. And I guess you could still fit it under this umbrella of arrhythmia-induced cardiomyopathy. I think the main headline point that I want to make here is that although it is, again, a very nice, neat diagnosis, it is not always clear what the cause is and what the result is. Is it the cardiomyopathy driving the PVCs? Is it the PVCs driving the cardiomyopathy? And also, once you get rid of the PVCs, do we see marked improvement of cardiac function? And if you pick your patients correctly, rhythm control and getting rid of the PVCs is a very effective way to improve cardiac function. But that's all hinges on this idea of picking your patients correctly. And so really, what does that mean to pick your patients correctly? And I think this is probably what I go through in my head when I'm trying to think, is this patient got a cardiomyopathy because of their PVCs? And so that would be a high PVC burden, which I would class as above 10%, and you want to really see that sustained over a significant amount of time. If there is significant ventricular dyssynchrony, as measured by the size of that QRS complex, if they've got a high symptom burden from the PVCs, that adds strength to your argument to do some form of rhythm control. But I think you want to make the patient aware of that rhythm control is not a holy grail. It is an option for these correctly selected patients. And if you are thinking of going forwards for ablation, I think what a electrophysiologist would really want to know is that the type of PVCs that the patient is having is amenable to a treatment like catheter ablation. And that would be, you've got a really nice monomorphic target in an accessible area. So it's important to try and capture the PVCs on a 12 lead to really inform that process, because what often happens is a patient can have a large number of PVCs when you see them in clinic, but then the stress, anxiety of going to the cath lab, perhaps some sedation, causes everything to go quiet, and that can make it really challenging to target something that you can't see. So getting as much data beforehand, having that nuanced discussion and conversation with patients about the risks of the procedure and the potential benefits is important. Great, so I'm going to stop there. And just go back to the objectives that we set right at the start, which is looking at the mechanism. It looks like it's not just tachycardia-induced cardiomyopathy. There is an irregularity component there. Secondly, in terms of your diagnosis, I think imaging is really important to make sure that you try and capture how much the ventricular function has deteriorated before, but then also after you do some sort of rhythm control, and then think about serial surveillance. And then remember that ablation is a class 1 indication for patients with a clear tachycardia cardiomyopathy, especially if that's not responsive to medications. And I think in patients with arrhythmia-induced cardiomyopathy, rhythm control treatments like ablation can be very effective, but it all hinges on selecting the right patients. And that applies for PVCs as well. And that's something that we still struggle with. And hopefully, in the coming years, we'll have better tools to guide us in making that selection. Thank you.
Thank you, Nikhil. That was a really great talk on arrhythmia-mediated cardiomyopathy, and you're certainly preaching to the converted here with regards to continuing heart failure meds. Just a note on that: we've had a few years old now, but the TRED-HF trial also gave us some further information on that regard. That in that trial, patients who had their heart failure meds taken away, about 40% developed further heart failure symptoms with reduction in ejection fraction. So these medicines really do need to be kept on board in the long term. So that's how we educate our patients in that regard. Do we have any questions coming in, Andrew?
There are none in the Q&A yet, so I would encourage all of our attendees to put their questions in the Q&A. I was struck by the high event rates in Brian Halliday's study. I don't know if that was that TRED-HF.
Yeah, that was TRED-HF.
Oh, okay. I mean, yes, so 45% of patients having an adverse event at follow-up if we withdrew medical therapy.
I think your talk outlined how important it is for us to work together. So not to just stop once we've managed the arrhythmia, we should continue with heart failure management as well. It's really important that arrhythmia and heart failure specialists work together. And that your first case illustrates that really well. That was clearly a DCM, and the EF was probably the straw that that broke the camel's back, but very important to manage his AF for his heart failure management going forward. I had a question about PVCs. This is something that I always find really difficult. Patients who have a high burden, but perhaps aren't symptomatic yet, their LV function looks okay, or it looks low normal. Quite often it doesn't look normal anyway because of the high burden, but they're asymptomatic. What should we be doing? Should we be bringing these people back to clinic, maybe on an annual basis? Should we be doing BNPs and looking out for signs that their ventricle is going to become problematic, or have they already self-selected themselves as being the individuals who won't have problems?
Yeah, I mean, that's the question, isn't it, right? What do you do with the asymptomatic PVCs? And there was a study from Canada, which perhaps one of the other speakers may know. I was trying to find it, where they followed up patients with PVCs for 10 years. And I think it was a Canadian study, and they found that once the really this high burden of PVCs can cause cardiomyopathy even a couple of years down the line. So even if it's not immediately obvious, you can see that deterioration in LV function as a time-dependent feature. So just discharging this patient who's asymptomatic with a good ventricular function with a high PVC burden may be missing that sort of cardiomyopathy and ventricular dysfunction. And so I guess the question is, if you see that, is that something you need to do something about? So is it, if you pick that up and if you do serially survey these patients who are asymptomatic, is that going to change your management? And what we know is that in the right patients who have got monomorphic PVCs, who don't have any other clear cause, they are good candidates for procedures such as ablation. But you know, you're jumping the gun and making several presumptions before, you know, starting them on an investigation sort of surveillance plan for something that you haven't picked up yet. And that study from Canada suggested that although this cardiomyopathy can develop over time, it can also resolve itself over time. And so, I mean, the truth is that I don't know what the best strategy is, and I think that involves talking to the patient, and if they do develop symptoms, have a very low threshold to bring them back and re-refer themselves back in for a repeat investigation. I think one thing that you would do is, if they do have a deterioration in LV function, is consider whether medical treatment would be something worth considering. So, you know, even if you take the sort of a procedural aspect out of it, there's still a strong reason for why you might try and suppress those PVCs in a pharmacological way if you're suspecting it's causing ventricular dysfunction. One thing that I showed, slide I didn't show, is that over time, what we know is that this sustained, at least in the atrial setting, but I don't know the data for the PVC setting, is that you do get this mild fibrotic response in the ventricle after sustained sort of insult. And so whether you see that following sustained impairment after PVCs, I don't know. We don't have that data yet, as far as I'm aware. So, you know, it's no clear consensus one way or the other, but I would have a low threshold to bring them back if
it becomes symptomatic. I don't know if this is a fair question or not, but obviously as heart failure specialists, we spend a lot of time looking at BNP measures. So we've obviously got the 2 and 6 week wait. Yeah. Someone's got an elevated BNP, they come to see us. Sometimes that patient will just have AF and it looks like their ventricle is normal. Are you aware of any data around BNP and AF? Should we still be worried about the ones who have a very high BNP at rest with a apparently normal ventricle? Have they self-selected themselves as being a more severe end of the AF spectrum, if you like, or is it indicating something else? I think we find this quite difficult in our clinic. We've got BNP of 2000 plus, but the ventricle's normal.
Yeah, I mean, it's something which we're studying at the moment. So the work we're doing is taking patients with AF and heart failure and trying to figure out what tools can help us select the patients who would respond best. And that's a group of patients with an impaired ventricle, but we're also studying patients with what looks like a normal ventricular function. And we're studying things like BNP to see, does that potentially help us select patients who would benefit the most or benefit the least? There was also one paper that came out of Brompton as a sub-study that suggested that maybe ANP, so atrial natriuretic is useful. And so it's something we're looking at as well, because maybe that would help us discriminate how much of the natriuretic peptide releases from the AF versus the LV dysfunction. But to me, that high BNP would be an indicator of cardiac sort of strain and struggle in AF or due to ventricular dysfunction. And so I'm not aware of any data that on itself at the moment is a marker for rhythm control or a guideline to go further with a more aggressive AF strategy, but it's something that we're studying at the moment. And so hopefully, in 2 years, we'll be able to give you some numbers and data around that.